Welcome to the UCSF Department of Medicine Medical Grand Rounds. To our Department of Medicine attendees, as well as our many guests at UCSF who are joining us today, our plan is to distribute this video broadly beyond UCSF after we're done, so welcome to all of you outside our community. My name is Bob Wachter. I'm professor and chair of the UCSF Department of Medicine. It goes without saying that these are extraordinary times. Even folks like me who've been in medicine for over 30 years have never seen anything like COVID before, as a clinical and a public health threat, as well as a test of our political and economic systems. At UCSF, I have to say the response has been breathtaking. Everyone has rolled up their sleeves and just done what needs to be done. The teamwork, the camaraderie, the intellectual firepower being applied to this challenge, and the courage and bravery that I have witnessed has been absolutely remarkable. I want to thank all of you for doing what you're doing to prepare for this crisis and to care for our patients, for each other, and for yourself. Over the last couple of weeks, we've received a staggering amount of new information. The UCSF Command Center and many others throughout the organization are working 24/7 to develop and disseminate new guidelines and algorithms, to stand up new services, and to troubleshoot what seemingly infinite number of challenging situations and unanticipated consequences. They've done an amazing job of doing all of this and communicating it broadly to the UCSF community. Today, we're going to focus a little bit less on the nuts and bolts of our response, although we'll cover some of these in the panel discussion toward the end of this session, and more on what we are uniquely positioned to do as a world-leading academic department and medical center, namely to understand and advance the science of epidemiology, virology, pathophysiology, clinical medicine, and therapeutics. We have 4 outstanding speakers to do that. A little roadmap for this session. The session will go for an hour and 40 minutes or so. The first hour, we'll hear from 4 of our expert speakers who will deliver brief lectures, followed at the end by a Q&A session. The questions will come, for the most part, from our audience who submitted questions during the live session. The questions are being reviewed by my colleague, Quinny Chang, who's feeding the most generally interesting ones or most commonly asked questions to me. At the end of that, which will be about an hour from now, we'll have a panel discussion with 5 other exceptional experts covering a variety of fronts from virology to epidemiology to clinical care in the hospital, clinical care in the ICU. And in that session, I will moderate a lively panel discussion. And so the entire session will go about an hour and 40 minutes. I think you will learn a tremendous amount, and I look forward to it. So let's go ahead and start with the first speaker. My intros will be brief to be sure we have time for the talks. Diane Havlir is professor and chief of the Division of HIV, ID, and Global Medicine at Zuckerberg San Francisco General. She's one of the world's experts in clinical research and the care of patients with HIV. And her presentation will focus on epidemiology and virology of COVID-19. Diane.
We can go to the, welcome everybody. Thanks, Bob, for the introduction. Can we go to the next slide, please? So COVID-19 is the name of the disease caused by the newly discovered SARS-CoV-2. SARS-CoV-2 is genetically related but distinct from the virus that caused the SARS epidemic in 2002. You can see here in the cartoon, this single-stranded RNA virus has characteristic crown-like from the Latin corona spikes on its surface. There's a close-up here shown of one of these spikes, the structure of the spike. Now, SARS-CoV-2 binds to the ACE2 receptor in epithelial cells in the upper respiratory tract, and alveolar cells in the lung, and glandular cells in the gut. Coronaviruses were discovered in the 1960s, and they're widespread in humans and animals. Most are non-pathogenic, and they cause about 10% of colds in humans. However, there are several pathogenic strains, highly pathogenic strains that caused the SARS epidemic, over 10,000 patients in 2002, and Middle Eastern Respiratory Syndrome in 2012, or MERS. Next slide, please. So the COVID-19 outbreak started in Wuhan, China, which is a city with a population of about 11 million in probably November of 2019. The first officially reported cases to the CDC and the government were in December 27th, when a physician noted 3 SARS-like pneumonia cases in a family in the hospital. Cases began pouring in. By December 31st, there was a public health alert. By January 7th, the virus was isolated and sequenced. By January 11th, there was a PCR diagnostic. This is really amazing progress, and all of this was shared with the world. January 23rd, Wuhan City was shut down for public health measures. But in this short time period, there were over 100,000 cases and 3,800 deaths. Next slide, please. So let's look at some key epidemiologic questions. What is the source of this virus? Well, the source appears to be the Rhinophilus bats. They harbor a number of coronaviruses, but they also harbor SARS-CoV-2, which doesn't cause any disease in them. Now, our other SARS, both SARS and MERS, had intermediary hosts, and one of them, for SARS, it was the palm civet, which is a small mammal, which was actually culled during the course of the epidemic. And for MERS, it was the camel. Some early reports suggested that the pangolin, shown here, whose scales are used in traditional Chinese medicine, were a possible secondary host. However, that was when only part of the virus was sequenced, and that has not been corroborated. So we still don't know if there's a secondary host. So how is this virus transmitted? The primary mechanism of transmission is through large viral laden nuclei and airborne droplets. When people talk, when they sneeze, when they cough, virus is transmitted. People touch these secretion surfaces and then touch their face and their nose, and this is the main mechanism. Now, I shared with you that this virus can infect gut cells, and in fact, it's secreted. It can be detected in fecal specimens. However, a large body, I would say, of epidemiologic data would suggest that this is not the main source of transmission. Next slide, please. Next slide. So let's look at the, thanks. Let's look at the viral dynamics of this disease. What we see is the virus peaks early and at high levels. On this graph, you can see individual PCR levels in patients infected with COVID. When we compare this to SARS, it peaked about 3 to 5 days earlier, and the peak levels are 1,000-fold higher. And this may be one of the reasons why this virus appears so much more transmissible and contagious. There was also a really nice study looking at transmissibility of when this virus is most likely to be transmissible that did both culture and PCR sequentially on patients after the onset of symptoms. And what they showed is there was no culture positivity after 8 days, suggesting that transmissibility decreases after that. We do know that viral shedding can outlast symptoms for days, and the virus can be detected by PCR in the stool. Next slide, please. So as we know, COVID spread rapidly inside and outside of China between January to early March. This is a WHO graph by region of the world. And what we can see is the virus started, as I mentioned, in China, that's the orange bars, and also in other hotspots in Asia, such as South Korea. This was followed by an increase in case reporting from the Middle East, specifically and mostly in Iran, where the epidemic continues to be raging. After this, we can see the red bar, which represents cases reported from Europe, and this is primarily driven by the cases in Italy. And finally, on the far right are the Americas, which you can see are just starting. Now, in this graph, you can see the green bar, which is the Diamond Princess cruise ship. We could kindly go to the next slide. And cruise ships have been a significant contributor to the transmission of this virus around the world. Now, many infectious disease people wouldn't go on cruises because they know there's such an increased risk for outbreaks of many different pathogens. Norovirus, a self-limiting gastrointestinal illness, the Maserati, rapidly can spread through populations. Influenza and other viruses are often outbreaks that can occur, and more common outbreaks that occur on cruise ships. Cruise ships may be enriched for at-risk populations, such as elderly populations. Also, cruise ships' air circulation systems do not have HEPA filters. in contrast to airplanes, which do have air that go through HEPA filters, originally developed because people were smoking on trains to filter out particles. With these filters also filter out pathogens. So there's multiple ongoing COVID outbreaks on cruise ships. In fact, some cruise ships are still at sea. We all watched with duress the story of the Diamond Princess, out bay or docked off of Yokohama, and during that time period, 696 confirmed cases of COVID were found in 6 deaths. Locally here, the Grand Princess was on our shores. In fact, I could look out my window and see this cruise ship. It was finally docked in Oakland on March 10th. Of the first 42 people tested, 21 were positive. These individuals, all of them now are being tested at federal sites. The next slide, please. So here's the map of the global spread. The reported cases are already over 200,000. We have over 10,000 cases in the United States, and a couple of points here. The new epicenter of the epidemic is in Europe. We have increasing number of cases in the United States, and in South America and in Africa, we have a low but increasing number of cases. Of course, the case detection has been limited by testing, and we expect to see these numbers increase. On the right side of this slide, you can see the top 10 countries by cumulative cases. The top 3 are China, Italy, and Iran. The United States right now sits at number 8. Next slide, please. So this graph has been widely disseminated, which shows the natural history of a pandemic in the solid figure when there are no interventions. What we would like to gain in our interventions is to decrease the slope of the rise of new infections and the peak. And this is been called flattening the curve. We do this by a number of ways. We first try to contain the epidemic using measures such as isolation, quarantine, infection control, and public education on respiratory hygiene. You are all familiar with that. But for some infections and some outbreaks, such as COVID-19, this is clearly not enough, and we need to do population measures. And these include social distancing, restricting community events, and a new term that we all have now is shelter in place, which is really widespread community quarantine. Next slide, please. Many of you have heard of the term of R sub naught, which in the most simplistic terms is the number of secondary cases that result from an index case and are a measure of how the population is, how the virus is driven through a population. So just for some perspective, infections like whooping cough or measles have an R of about 18. In COVID-19, the R is estimated to be about 3. We can affect R, and this has been called RE, by intervening on a number of points through public health measures, as shown here on this slide. Next slide, please. So let's go back to Wuhan. China implemented rapid and extensive universal population response with isolation, quarantine, suspension of public gatherings, and movement restrictions. It was quite amazing. At one point, they had asked over 1 billion people to stay at home for 2 weeks. With this, and you can see the graph of Wuhan on the right, there was a dramatic reduction in the number of cases. And we just heard from China that over the last 24 hours, they've seen no new cases in this region. Also shown on here, you can see the R values decreasing over 4 intervals over time from 3.86 to 0.32. Next slide, please. So every pandemic requires a new playbook, but we look to lessons from the past for each epidemic that can help us to respond. There was a very nice paper in JAMA that looked at the influenza epidemic in 1918 across a number of cities, and I'm showing 2 of these cities here. So this compares St. Louis, where there was a very rapid response. They did school closures, banned public gatherings, and contrasted it to Pittsburgh, where there was a slow response and they did very few measures. And what one can see is when we look at the excess death rate, it was nearly twice as high as Pittsburgh as it was in St. Louis. So the lessons from here: begin social distancing interventions early and keep them going. And I think we've seen some success in China and some other Asian countries such as Taiwan with this approach. So this has been an overview of the epidemiology of this mighty virus. and how public health measures can be effective as we work around the clock to develop treatment and vaccine for this disease. Thank you.
Diane, thank you so much. That was terrific. I'm going to save questions now till the end. We're a little behind time. So let me move to the next speaker, who is Dr. Jen Babik. Jen is Associate Program Director for our Internal Medicine Residency Program and Associate Professor in the Division of Infectious Disease here at UCSF Health, and a go-to clinician educator for all of us. And she's going to talk to us about some of the clinical manifestations of this new disease. Jen.
Thank you, Bob. Thank you for that very kind introduction. So I'm going to talk today about the clinical manifestations of COVID-19. Next slide, please. So we'll start with the clinical presentation, and I want to start with a couple caveats to this data. So most of this data comes from China, Singapore, and Korea, with a little bit of data now coming out of Italy. And then another caveat is that almost all of this data is from hospitalized patients with COVID. So I want to start by looking at the pie graph to the right to talk a little bit about disease categorization. So you can see that most of the patients with COVID do have non-severe disease. So about 70 to 80% have non-severe disease. 15 to 25% have severe disease, and 5% end up in the ICU. In terms of the symptoms, and again, this is hospitalized patients, most patients have fever at some point, but only about 50% have fever on admission. And that's important because the lack of fever on admission does not exclude COVID as a diagnosis. Cough, shortness of breath, and myalgias are also quite common. But the triad of fever, cough, and shortness of breath are only seen in about 15% of cases. In terms of some less common symptoms, so URI symptoms, including headache, sore throat, and rhinorrhea, are seen in less than 15%. And then GI symptoms with nausea, vomiting, seen in less than 10%, and diarrhea seen in less than 25%. Next slide, please. In terms of labs, in terms of looking at routine labs, the median white blood cell count in most patients is normal, with a leukopenia seen anywhere from 17 to 54%, and a leukocytosis being relatively uncommon, seen in less than 25% of cases. Lymphopenia can be seen in anywhere between 33 and 85%, and so importantly, leukopenia and lymphopenia can be important clues to COVID. The median platelet count is normal, although there can be a slight decrease in platelets in less than a third of patients. And then you can see an increase in the AST/ALT in anywhere from 4 to 35%. There's been a lot of excitement about thinking about biomarkers to help try to distinguish between COVID and other diseases. Unfortunately, CRP and LDH are increased in a fair proportion of patients, and so don't have very good discriminatory value. The procalcitonin cutoff that's used in most of the Chinese studies where this data comes from is 0.5, and that's important because that's higher than the cutoff that is used in most of the algorithms in the US. But they found that procalcitonin was greater than 0.5 in anywhere from 5 to 10% of patients, although in patients who were more severe or in the ICU, it was higher. So a low procalcitonin in someone with mild disease may be helpful, but high procalcitonin, especially in severe disease, cannot be used to exclude COVID. Next slide, please. There's been a lot of attention paid recently to the question of viral and bacterial co-infections. So in published reports to date in adults, the co-infection rate appears to be between 0 and 6%. However, it's not clear if testing was systematic in all of these studies, so this very much may be an underestimate. There are multiple cases reported of co-infection with other respiratory viruses, including influenza. And there is a report that many of you may have seen that is circulating now from Stanford on social media that shows that they have had a higher co-infection rate. That is not yet published or peer-reviewed, but something I think that everyone is paying attention to. So I think the detection of an alternative viral infection makes COVID less likely, but does not rule it out. And similarly, bacterial co-infection likely increases with the severity of illness, as we know it does with influenza. So bacterial infection in a severely ill patient should not exclude COVID. Next slide, please. We've had a lot of questions recently about asking about the clinical course for COVID. So this comes from a study that came out in Lancet last week of 191 hospitalized patients in Wuhan who had a known outcome. And that's important because a lot of the prior studies had patients who their outcome was actually not yet known. They were still hospitalized with COVID. So these are patients where the outcome was known. They were either survivors and were discharged, or they were non-survivors. So they looked at 137 survivors and 54 non-survivors. And they looked at several parameters, which are shown in the colored bars over time, which is shown basically in the x-axis. And so if you look at fever and cough, which are the orange and the light blue bars, most patients had those kind of from the beginning onwards through their course. Dyspnea, which is the dark blue bar, begins around day 7. ICU admission happened around day 12 in both groups. And then for those who needed to be intubated, which happened almost exclusively in the non-survivor group in this study, that happened around day 15. And for the non-survivors, the median time of death was day 19. And for those who survived, they were discharged around day 22. And you can also see they have different time points here with the arrows. Sepsis tended to occur around day 9 or 10, and ARDS around day 10 to 12. And importantly, we don't yet know how the clinical course will vary with different patient populations, such as immunocompromised patients or patients with HIV. That data is not yet out there. Next slide, please. In looking at the case fatality rates, these vary depending on the country. So in China, it's been reported that their case fatality rate is anywhere between 2.3 and 3.8%. The data that came out of Italy this week showed a case fatality rate preliminarily of 7.2%, whereas in Korea, the CDC report from Korea this week showed a mortality rate of 0.5%. And some of the differences between countries are likely in part due to testing. So we know in Korea there's been widespread testing, so they're likely picking up many of the mild cases. So it may be that this is a more accurate number. The other parameter that may be causing some of the higher mortality in Italy is the age of their population. So they have the oldest population in Europe. And as we'll talk about, we know that that is a factor in mortality. So older age is the main risk factor for death when it's been looked at in a few different multivariate analyses. Other factors that seem to be associated with higher death rates are, at least in China, men in many studies had higher mortality rates than women, and then comorbidities. And the ones that were commonly reported in the Chinese literature were cardiopulmonary disease, diabetes, hypertension, and some with cancer. So I've shown a graph here of the case fatality rate with the red bars from China and then superimposed the newest Italy data in the blue text, but they're very similar. And you can see that the case fatality rates really start to increase once you get to the ages of 50 to 60. And really over 70 to 80 is where the mortality rates really get higher, anywhere from about 10 to then 20% over the age of 80. Next slide, please. Some of you may have seen that the MMWR came out yesterday with a preliminary analysis of the United States cases to date. So this is a look at the first 4,226 cases in the US. And you can see the pie graph showing the case distribution by age. And there's a very wide spread of age distribution at the moment. And this certainly may change as our testing strategies evolve. But you can see that importantly, and similar to other data from other countries, that only 5% of our cases are in people less than the age of 20. If you look at the table, they stratify by age group, which is the left-hand column, and then they look at rates of hospitalization, ICU, and case fatality rate. And there's a range of data here because they had a lot of missing data, so they tried to give estimates. But you can see that the rate of hospitalization, ICU admission, and case fatality rates all increase with age group. And the preliminary estimate of our case fatality rate, and again, this is very preliminary data based on only our first 4,000 cases, but was 1.8 to 3.4%. And one of the take homes from this study is that adults greater than 65 years, while they were only 31% of cases, they were 45% of hospitalizations, 53% of ICU admissions, and 80% of deaths. Next slide. So I just want to end by saying I think that everyone should be thinking about taking a diagnostic timeout when you are seeing patients with COVID. I think we're all bombarded with information about COVID from all angles in every aspect of our lives right now. And it's tempting when you see these patients to think in a very binary COVID, yes, no. But I think it's really important to take a time out and think about all of the normal diagnoses that you're thinking about, and making sure you're keeping your differential broad. And I personally have felt like I've needed to do that when evaluating patients. So that's my last slide. Thank you everyone for listening.
Thank you, Jen. That was terrific. Let me ask one quick question. Maybe it's not a quick question, it's a hard question. Diagnostic testing and its utility, particularly since no symptom is 100% sensitive, or you see symptoms that are 75% have fever or whatever. So how do you decide on diagnostic testing? We're starting to hear about people who were asymptomatic, got tested, and were positive.
Yeah, that's a great question, Bob. And I know that I'm sure Chaz will discuss this later on the panel as well, but I think it depends on your availability of testing. So I think, we now at UCSF have quite widespread availability of testing. So we're testing a lot of people because, as you said, it's really hard to tell whether it's COVID or whether it's influenza or metapneumovirus. I know that other places that have more limited testing are having to risk stratify a little more carefully, but that's very challenging because COVID looks like many other respiratory diseases.
Great, thank you. And again, we will talk about this more during the panel. And just to remind people, if you do have questions, please send them in through the Q&A function. We're seeing some chats as well, but we're monitoring the Q&A function for that. So Jen, thank you very much. Next speaker is Michael Matthay. Michael is professor in our Division of Pulmonary Medicine at UCSF Health. He's also Associate Director of Critical Care Medicine. More relevant to this talk, he may very well be the world's expert, certainly the top handful, in the syndrome of acute respiratory distress syndrome, and he will talk about that with a special reference to COVID. Michael, go ahead.
Thank you, Bob. So that will be the focus, ARDS. Next slide. So this is from the Philadelphia Inquirer yesterday. When coronavirus kills the lung condition, ARDS can be the culprit. Here's what you need to know. And so that really is the problem. Most of the mortality seems to be related to severe ARDS. Next slide. So what is ARDS? Many of us are quite familiar with this, but basically it's a patient who has acute respiratory failure with bilateral infiltrate shown on this chest x-ray and protein-rich pulmonary edema. It is a non-cardiogenic pulmonary edema. The PF ratio by definition has to be less than 300 millimeters of mercury. There are approximately 200,000 cases per year in the US before COVID-19. Mortality is 20 to 45%, depending on the initial degree of hypoxemia. And the clinical disorders most commonly is pneumonia, second non-pulmonary sepsis, aspiration, and trauma. Next slide. The pathogenesis of lung injury involves injury first to the endothelial vascular barrier, even if the primary insult is pneumonia, and then a breakdown in the epithelial barrier. There's a major role for neutrophils, platelets, and extracellular traps, and maybe also in other cells such as lymphocytes and viral pneumonia. And there is, importantly, direct injury from pathogens and their products. And as ICU doctors know, non-pulmonary organ failure and comorbidities contribute to the higher mortality in these patients. It's not just the lung injury. Although with a viral pneumonia such as COVID-19, it really is often an example of just severe respiratory failure. Next slide. This slide just briefly shows that we've learned a great deal about pathogenesis of lung injury as well as repair. We now have several different pathways identified. It's complex because it involves the vascular and the epithelial barriers, but at a molecular level, we have learned a lot in both of these areas. Next slide. So the clinical features of ARDS and COVID-19. Well, some patients will present just with pneumonia that does not necessarily require ICU care, but may worsen in the second week of hospital care. ICU care approximately in 20 to 30% of hospitalized patients, ARDS perhaps in about 17 to 29% of hospitalized patients, and mortality perhaps, depending on more data, about 4 to 15% of ARDS patients, and as already shown by Jen, higher mortality in patients with age greater than 70. Next slide. The next three slides will show chest radiographic and CT findings. This shows on the left-hand side, a chest x-ray that shows a minimal infiltrate in a COVID-19 positive patients that's confirmed on the CT scan. Next slide shows now bilateral infiltrates in another patient that's very evident on the CT scan, though a little bit faint, but this is the next phase. And then the next slide shows the infiltrates more extensive and a more impressive ground glass appearance, as well as on the CT scan. Next slide. Now, the lung pathology is quite interesting. It shows classic features of ARDS with protein-rich edema and fibrin debris. But interestingly, a lot of mononuclear cells, including lymphocytes, and to show that the extent of the injury, the alveolar epithelial cells are denuded, and there may be evidence in this recent publication of actual viral inclusions. So the lymphocyte and the mononuclear collection in the lung is perhaps a fairly unique feature of this syndrome. Next slide. Now, not everybody who develops respiratory failure will need intubation. In fact, we are recommending, as we'll probably discuss more in the discussion section, that patients who are not rapidly progressing to severe respiratory failure be treated with high-flow nasal oxygen. This is a slide from the classic study from France in 2015 that showed that high-flow oxygen was more effective in saving patients. So that's a key alternative. Now, for the specific respiratory treatment of patients with COVID-19, low tidal volume is the key, most important treatment. PEEP at a moderate level, neuromuscular blockade if the patients have ventilator dysynchrony, high airway pressures, or hypoxemia, and prone positioning if the PF is less than 100 or 150. Next slide. Just to emphasize a very important point, low tidal volume is really save lives in this syndrome. And just to emphasize, we learned that the low tidal volume is associated with a marked reduction of IL-6, IL-8, TNFR1, and other pro-inflammatory factors. So one of the reasons it worked is that it reduced lung injury. Next slide provides a diagram to just illustrate how the low tidal volume attenuates the lung injury and allows the endothelium and the epithelial barriers to repair themselves. And this is a key point. In giving low tidal volume, the patient is set on the course of having a better chance for recovery. Next slide. This is the slide, the figure from the prone positioning trial published in the New England Journal in 2013 that showed that prone positioning definitely increases survival in patients who have moderate to severe ARDS. And this is an important treatment objective and definitely is added to the treatment of these patients. Next slide. What are the adjunctive treatments for COVID-19 ARDS? Well, inhaled nitric oxide can be used for refractory hypoxemia. Fluid balance, is probably important to use moderate fluid resuscitation for these patients so as not to overload and increase the risk for more pulmonary edema. Based on the New England Journal publication 2006, we know that a conservative fluid strategy targeting negative fluid balance is also beneficial. Dialysis can be used with continuous veno-venous filtration for oliguric renal failure, pH less than 7.2, and negative fluid balance. And if all that fails, and if the patient is appropriate, ECMO can be considered. There's an international group working with ECMO now, and so patients have been treated with ECMO, though many can survive without ECMO. Next slide. What are possible other treatments for COVID-19 ARDS? Well, we think glucocorticoids are not recommended. We can discuss this more in the panel period. Other experimental therapies that are being considered included anti-IL-6 or IL-6 receptor blocker therapy, IL-1RA, or interferon beta, but they all have concerns, and particularly the anti-cytokine therapies might reduce host defense. We do have a program here at UCSF that's a multi-center study for using allogeneic mesenchymal stromal cells, which are attractive because they have multiple mechanisms by which they can decrease injury and increase repair. And this is a phase 2b trial that's ongoing at UCSF, both San Francisco General and Parnassus. Finally, I should point out another interesting alternative, which is high-dose vitamin C. We're about to start a phase 2 trial here at UCSF and 11 other medical centers, but there's a very favorable trial, blinded and randomized, phase 2, showing high-dose vitamin C reduced mortality in patients with ARDS before the COVID-19 outbreak. I think that's the last slide, Bob.
It is, Michael. Thank you so much. That was terrific. Let me ask you one sort of general question. Annie will speak about therapeutics more specifically, but from your decades of studying ARDS, is an antiviral potentially going to be the answer here, or does the virus come in and do its damage and then sets off a cascade of non-viral pathophysiology that really is what's harming the lungs?
I'm going to defer to Annie on this point, but I would say most likely when the patient has arrived in the ICU and has developed severe respiratory failure, I would anticipate antiviral therapy would not be effective, but I think Annie can speak to this better than I.
All right, fantastic. Thank you, Michael, very much. So our last formal speaker, and then after this, starting at 1 o'clock, we will have a panel of 5 other speakers just to increase the number of degrees of freedom in our Zoom event here. But our next speaker is Annie Luetkemeyer, who is a professor in the Division of HIV Infectious Diseases and Global Medicine based at Zuckerberg San Francisco General Hospital, where she directs the HIV clinical trials group and is now quite involved in helping to lead clinical trials around COVID here at UCSF. Annie, thank you for speaking.
Thanks so much for including me, Bob. I'm going to go to the next slide. So I want to talk about who we should treat, when we should treat, and then what we should be treating with in this overview of COVID treatment. So Jen Babik nicely reviewed for us that the majority of people do not develop severe disease and will recover and do very well without any kind of medical intervention. So this has led us to trying to prioritize who we need to develop treatment strategies for. Obviously, it's a high priority to treat the people who are severely or critically ill in the ICU. We certainly are thinking about treating people with moderate disease. In other words, those who have developed hypoxia and may be hospitalized, but they have not developed severe disease requiring intubation. And we're trying to risk stratify those individuals by the risk factors that Dr. Babik mentioned. I think an unanswered question is those with mild disease. Again, we have an initial signal for those people who have risk factors for poor outcomes. Should we be trying to treat those individuals when they're at home? We don't know the answer to this, and a part of this will depend on whether we have a safe and widely available treatment, in which case we could consider trying to expand to those with mild disease, particularly if they have risk factors for a poor outcome. Many of these individuals will recover and do very well without treatment, but one other thing to consider when we think about the rationale for treating people if they have mild or moderate disease is that if we have something safe and effective that reduces the viral load dramatically in the beginning, this could be a potential strategy to reduce infectivity and to try to break the cycle of forward transmission. So we certainly would like to have a tool that would allow us to do that. And then many questions about prophylaxis, post-exposure prophylaxis for those who've been exposed, and how do we help protect people on the front lines? And I'm going to talk a little bit about that at the end of this talk. Next slide. So when do we treat people in the course of disease? And Dr. Matthay and Dr. Wachter brought this up. You know, when has the horse left the barn, so to speak, in terms of treating the virus? And this has to do with the 2 phases of disease that we think of in COVID disease as we understand it now. In early disease, during this first week, we know that this is the time when the viral load is the highest, but oftentimes it's not when people are at their sickest. So this can be a time, maybe the best time to intervene with antiviral approaches that may allow for a rapid reduction in viral load. And the goal here is to prevent ARDS and hopefully to reduce death. We know from the SARS era that the limited antivirals that we had during that time, including drugs like lopinavir, ritonavir, looked like they worked reasonably well in some studies in those with very early disease, but once people had developed full-on ARDS, it was not effective to provide these therapies as rescue therapy. When you think about later disease, so oftentimes this is in the second week of disease when people's viral loads may start to come down, but you start to see a very robust inflammatory and immune response. This is often when people will deteriorate and become much more ill and end up in the ICU with things like ARDS. At this point in time, the horse may have left the barn because you have a robust cytokine response that may be triggered and frank ARDS may be present. There may still be a role for treating with an antiviral. We don't know, and we need to understand this better. But the most effective approaches may be those that help to mitigate lung and myocardial injury. We know that cardiac injury is a big part of what leads to death, particularly in older patients, and that we need strategies that go beyond treating the virus that are going to be anti-inflammatory and deal with the dysregulated cytokine overload that's happening. So cytokine modulation is going to be important. Next slide. So how do we treat people with COVID? Given the breakdown that I've provided of these sort of two phases of disease, we've divided this into two main buckets as we think about therapy. There's the antiviral approaches and then the anti-inflammatory or immunomodulatory approaches. I want to just say right off the bat that right now we don't have any approved therapies, FDA approved or strongly evidence-based approved therapies for COVID right now. We do have medications that have been used for other reasons that are being investigated in, very actively, and we do have some medications that are available and being used in an off-label way. But I want to just give that caveat to what I'm presenting here, and we'll give you sort of our best interpretation of what's being studied and what to do right now when we have people in front of us. For the antiviral bucket, I'm going to talk about three approaches, recognizing that there are many, many more than this, but remdesivir, chloroquine, hydroxychloroquine, and lopinavir, ritonavir, I think are the ones that have really been in the forefront. And I'm not going to get too into the anti-inflammatory and anti-cytokine approaches, as Dr. Matthay reviewed those, but to recognize that there are many exciting approaches that are being investigated currently. Next slide. So I want to start by talking about the antiviral remdesivir. This is an adenosine analog that inhibits RNA-dependent RNA polymerase. It has broad antiviral activity in vitro and had activity against other coronaviruses like SARS and MERS that Diane mentioned, wide activity against a number of hemorrhagic viruses, including the Ebola virus. Interestingly, remdesivir was studied in a clinical trial against Ebola where it did not look particularly effective. And what we don't know is if part of that reason that it didn't work well is that people already had quite severe disease when they were treated. We know that in the graph on the right-hand side, this shows us that remdesivir has in vitro activity against the virus that causes COVID, SARS-CoV-2. And you can see that at concentrations that are attainable with IV therapy, that there is quite a robust suppression of the virus without accompanying cytotoxicity. So at least there is an in vitro signal that remdesivir is active against this virus. There are 5 RCTs at least ongoing around the world that are evaluating remdesivir. We're participating at UCSF at both the UCSF and San Francisco General campuses in one of these. In this study, it provides 10 days of IV remdesivir versus placebo for hospitalized COVID-19 patients, and this is double-blinded. The eligibility includes moderate to severe disease, so individuals who have radiographic abnormalities or have hypoxia. If you are at one of these 2 campuses and you have patients that may qualify, you can contact the COVID ID service to discuss enrollment, and you're always welcome to reach out to me directly, and we could try and get you in the right direction. Next slide. Another group of drugs that has received a lot of interest at this point in time are the anti-malarial drugs, chloroquine and hydroxychloroquine. So chloroquine is an anti-malarial that has antiviral and anti-inflammatory activity. There are several possible mechanisms by which this drug may impact COVID. It appears to interfere with viral entry by changing the acidification inside of the cell. It may inhibit glycosylation of the SARS-CoV-2 receptor, thereby helping to block entry into the cell as well. And it has immune immodulating activity, and with hydroxychloroquine in particular, some immunosuppressive activity. And you can argue whether this may be a good thing or a bad thing, and I think we need to learn more about it. In vitro, on the graph on the right, we can see that chloroquine does have activity similar to remdesivir, where with orally given doses, you can achieve virologic suppression of the SARS-CoV-2 virus. Some good things about chloroquine are that it's inexpensive. It's been used for many, many years for malaria. It's been used widely in the COVID outbreak in China, and there are reports that state that it improves pneumonia, viral clearance, and the disease course, but these have not been reported as have not been reported very vigorously, and there have been no data, to my knowledge, from randomized controlled trials, so we very much would like to have some more rigorous data here, and there are many RCTs that are ongoing. Some considerations with chloroquine is that it requires a higher dose than for malaria. Typically in the COVID studies, they've been giving 500 milligrams BID, which may lead to concerns about increases in toxicity and drug-drug interactions. And this is not a drug that we have a large US supply for. Next slide. This has led to a lot of interest in an analog of chloroquine, which is called hydroxychloroquine, which is molecularly very similar with the addition of or substitution of a hydroxyl group here. And this may be attractive as an alternative agent to hydroxychloroquine because you can really push the dose orally. It has less drug-drug interactions when compared to chloroquine, and it may be more tolerable. Some initial in vitro data that were just published last week suggest that it may be more potent against COVID than chloroquine, and these are two graphs down below that show at similar concentrations, and it looks like hydroxychloroquine may be more active in terms of suppressing the virus than chloroquine. I think the jury is still out about the appropriate dose for hydroxychloroquine, and it may be that we need to give it at higher doses than given for rheumatoid arthritis, and possibly even higher doses than given for Q fever. Next slide. There was a very interesting article that just came out yesterday and is in preprint from a group in France. This is a randomized open label study. I'm sorry, it was a non-randomized study that was open label, so comes with many caveats, and it was relatively small. A little over 50 patients were enrolled. These were individuals who had confirmed COVID disease, and they were offered hydroxychloroquine to take orally, and was given either with or without azithromycin, and that was at the discretion of the clinician. People who declined to take hydroxychloroquine were in the control group, and that comes with all of the potential biases and confounding factors there. That being said, what they were able to report out in this preprint yesterday is that those in the control arm, which is in black and the top bar here, 16 of those, we're looking at the viral dynamics over the first 6 days of medication administration. And you can see that the quantitative PCR for SARS-CoV-2 really did not go down. By contrast, those who were given hydroxychloroquine showed a decline in the SARS-CoV-2 viral load. And when azithromycin was added, and this was a very small number of people, that was only 6, then you can see that the viral load came down even more. I think we have to interpret these with great caution. This was not randomized, but it certainly does show a promising signal that hydroxychloroquine may indeed have in vivo effect, and it's being studied very actively in a number of randomized controlled trials around the world. Just a note that the dose that they gave was 600 milligrams for 5 days, which again is a higher dose than is given in rheumatoid arthritis. This is a Q fever dose, and there's some suggestions that possibly even a higher dose might be preferred to really optimize the response. I think this is an area where we need to stay tuned. Next slide. And then lastly, there's been a lot of interest in lopinavir ritonavir, which is known as Kaletra. This is an older HIV protease inhibitor that we're familiar with from the earlier HIV treatment days. It is still available and used for HIV treatment. It has in vitro activity against other coronaviruses, MERS and SARS, and was widely used in the first wave of the COVID epidemic in China. And there have been many questions about whether or not this actually has impact on the clinical outcome. So yesterday, one of the first randomized controlled trials, or the first randomized controlled trial that I'm aware of, was published with results. This was an open label randomized controlled trial of Kaletra in hospitalized COVID patients. And I just want to point out that this population had a couple of interesting points. 33% were on steroids. Steroids remain a controversial area here. It is not clear if steroids are harmful or helpful. In general, we have at this point been trying to stay away from steroids, and they may impact the time of virologic shedding. So 33% of individuals were on steroids. They started relatively late, so the median was 13 days from symptoms to the time of treatment start. Remember, we talked about whether what is going to be effective once you get into this second week, and that all antivirals might be, it might be more difficult for them to have effect once people are sick. And importantly, this was a sick population, so there was a 22% mortality in all comers here. So these were folks who were very ill and had a high mortality rate. And again, that may not be the group in which antivirals alone work well. All of that being said, we can see in the left-hand panel, when you look at lopinavir ritonavir in red versus the controls in blue, there was no change in the time to clinical improvement in the intention to treat population, and this was their primary endpoint. This did not change when they looked at whether people were treated earlier, so sooner than 12 days, or if they stratified by people who were less sick at the time of enrollment. Similarly, if you look at the right-hand panel, they looked at the virologic decline in the red, which is Kaletra, versus the blue, which is the control, and they did not see a statistically significant difference in the viral load decline. You can see that the viral load comes down in both arms, which is expected over the course of the disease, but it doesn't look like Kaletra on its own is really impacting the virologic decline here, unfortunately. So my take home from this is that we certainly are not seeing the strong signal that we would want to see for Kaletra. Perhaps this is because people were quite ill, but nonetheless, I think this dampens the enthusiasm for the use of Kaletra right now, but we certainly welcome more data, and I know there are a number of randomized controlled trials that we're awaiting the readout for. Next slide.
Andy, we're going to have to finish up in just a sec.
Yep. There are many more. I looked yesterday on the WHO website, 392 and counting clinical trials. They look at antivirals on the left. There are many there, and other mechanisms on the right. Next slide. So how are we managing this right now, given the data that we have and importantly, the data that we don't have? These are the San Francisco General Treatment Guidelines that are in evolution. They're very similar to the UCSF treatment guidelines. We've tried to stratify by the severity of disease. So for individuals who are on ICU level care with or without intubation, very important to maximize our appropriate ARDS management. Think about ARDS targeted therapies like mesenchymal stromal cells, and still consider providing antivirals like remdesivir through a randomized controlled trial or compassionate use. Just a note on compassionate use that it's only available to individuals who are intubated, but they can't have end organ disease or be on pressors. So it tends to be a bit of a narrow slice there. For those who are hospitalized and have non-ICU level care, so moderate or severe disease, if possible to enroll in a randomized controlled trial, that's the road we've been going down, but we have been offering hydroxychloroquine to individuals if remdesivir is not feasible. For those with mild disease, but who have risk factors for progression to severe disease, such as age or other comorbidities, we consider hydroxychloroquine. But for those who have who have mild disease now and no risk factors, at this point we are not offering them treatment. Next slide, and this is my last slide. I just want to end with just a discussion of post-exposure prophylaxis. There's a lot of concern about household contacts and healthcare workers with direct and known exposures to COVID and how to handle this. It's an area of very active investigation. We hope to participate in a multi-center RCT looking at hydroxychloroquine, and there are many other efforts underway. Pre-exposure prophylaxis is brought up. I've been asked this question many times. I think we need to understand and explore this more for those at highest risk who are on the front lines, and we hope to have more data to inform us here. So I will go ahead and end there. I think we're going to move into the question and answer period for the panel.
Thank you, Andy. That was terrific. So let's, Kyle, if you could bring up the four speakers. That's Annie, Jen, Diane, and Michael. And so not yet the panelist list. We'll come to the panelists in a second. So we have questions from the audience. We got 143. Unfortunately, we can only ask about 3 or 4 given the time. And we'll have a little more time with the panelists in a few minutes. So let me, and by the way, we have 3,435 people watching this. So Diane, and if you can keep your answers brief, which is impossible because these are really hard questions. One of the questions was, what do you anticipate the epidemic will look like in the US in the coming weeks to months? And I'll throw in a little chaser, make it even harder. We see what's happened in China, but we're also seeing what's happening in Italy, perhaps a little bit of some of the curves getting better in Korea, and then maybe getting a little worse with recidivism. So as you factor all of that together, what can we anticipate in the US a month, 2, 3 from now?
I think what most people think, it's going to get worse before it gets better. We don't know how soon it's going to get better. And I would like to say that the data from China are encouraging. It's not just China where we've seen a decrease in cases. Countries such as Taiwan and Singapore, we've also seen good trends. The other thing about Italy, there are locations in Italy that started very early with population level interventions, and they have not seen the same increase in cases there. So that's my answer to that.
Okay. This could be either to, this is probably either to you or to Annie, I guess, in the, this is another crystal ball question. In the race between effective therapeutics and a vaccine, which one is likely to win? And be the first thing that comes to help us all out. Annie, you want to try that?
Sure. I mean, my understanding of the vaccine development is that we are looking at least 6 to 12 months out before we would have something that could be widely used. And I think that that is probably an overly optimistic estimate there. So I hope that we are well on the race to therapeutics now, given the number of studies that are ongoing and the just flood of information. But a vaccine is going to be really important. That work is underway. I just don't think there are ways to speed up vaccine work beyond how they've sped it up now, because there are some stages that they have to go through.
Right. Diane, any comment?
No, I think we need to do both. And I also think we need randomized trials for treatments, because that's going to probably be the only way if we know if something works.
Okay. Michael, and I think maybe Sarah will, or Debbie will address this also later, but the risk of nosocomial spread with high flow nasal cannula or non-invasive ventilation, any comment on that?
Well, just briefly, I think we definitely favor high flow nasal oxygen. The more concern about non-invasive ventilation for sure. So I think high flow is preferred. There's still concerns, of course, for spread of the virus, even with high flow, but it's probably more limited.
Okay. And in terms of other therapeutic targets, there's been some tantalizing information about nonsteroidals. And also, I think the target here may be ACE, and therefore people wondered about ACE inhibitors and whether anyone who happens to have gotten COVID who was on an ACE inhibitor, whether we're seeing any difference in outcomes so far.
Yeah, that's a point of question. I think that's not likely to be an issue for several reasons, and interest time I won't go into. But it is interesting that the virus probably, in part, will attach to the ACE2 receptor in the alveolar epithelium.
But the science of this would say, I mean, a simplistic mind like mine would say, oh, put everybody in an ACE inhibitor, but that would not be the right call.
Probably not, because it's the receptor that is going to determine the biologic effect of the virus, I think.
Okay. Annie, as one of the audience asked, is convalescent serum being considered as a treatment option?
Yeah, I've seen that, discussion of that being used. I'm not sure about the scalability there, but I think right now we are looking for anything that works, and then we'll sort out the scalability. So yes, I think that is being explored.
And Jen, as we're now taking care of these patients, still a relatively small number at UCSF, are you getting a sense, even if the data are incomplete, about which patients are likely to do well, which patients are likely to do poorly, or are we getting surprised?
Yeah, I think that's a great question, Bob. I think, as you mentioned, we've only had kind of a handful of patients that we've taken care of here. And I think we've seen a couple patients who have come in who have been critically ill, either when they've arrived or very soon after they've arrived. And those are the patients that we're really worried about. On the other hand, we've had a couple cases that have been very mild and have remained mild. So I don't think we have the numbers yet to really be able to predict. And even in the studies coming out of China, it's not really been clear how to predict who's not going to do well, except for the factors that have been mentioned in terms of age and comorbidities.
And the questions come up, sort of when are you out of the woods? In San Francisco now, everyone's supposed to be sheltering in place. And so there are a fair number of people that had sort of the regular exposures that one would have in their normal life up until, let's say, a week ago. If they're now home and really staying away from everybody and practicing perfect infection prevention, are they out of the woods, or do they still need a few more days, or how do we figure that out?
Yeah, I mean, we think the range in the incubation period is up to 14 days, which is why that's been recommended as the kind of quarantine period for people who have had contact with a patient with COVID. So I think, you know, our shelter in place order is 3 weeks. So I think to try to account for that, but I think the 2-week period is what we think is the upper limit of the incubation period.
Okay. All right, we could go on, but we've got 5 other spectacular experts who are ready to come on for another panel discussion. This one will focus a little bit more on this, the efforts that we're undertaking here at UCSF and our own experience around preparation and to some extent management and treatment. So let me thank the 4 folks who have spoken already, and Diane, Jen, Michael, and Annie for a terrific job. And I'm hearing all 3,200 people out there applauding. And let's bring on the next 4. So very brief introductions. Matt Aldrich is a professor in our Department of Anesthesia and runs our critical care units. Sarah Doernberg is an associate professor in our infectious disease division and also serves as the medical director of adult antimicrobial stewardship here at UCSF Medical Center. Chaz Langelier is an assistant professor in the division of ID at UCSF Health and an expert in virology and testing. Brad Monash is associate professor in medicine and pediatrics, also associate division chief in the division of hospital medicine, and helps run the hospital medicine response. And Debbie Yokoe is professor in ID here at UCSF Health and also the medical director of hospital epidemiology and infection prevention in adult medicine at UCSF Medical Center. So I'm hoping we can get all of those people up in Hollywood Squares. Let's be sure that that is happening. Deb. All right, and oh, I see everybody. Terrific. Okay. And I may be old enough that when I say Hollywood Squares, you know, people say, what exactly was that? It's, it's a little concerning. So thank you all for being here. So we've got about 25 minutes or so to talk through the elements of the epidemic that you're seeing and preparing for. I'll take advantage of some of the audience questions and throw out some of my own. So let me start with Matt. Probably the scariest things that any of us hear are the reports from the intensive care units in Italy about being overrun, running out of ventilators, and having to make choices I don't think we've ever had to make in American medicine about who gets a vent, who doesn't. So, first of all, is that what keeps you up at night? Second of all, how are we preparing for that? And third of all, do you think that might happen or is likely to happen here at UCSF?
It is what keeps me and many people up at night. I think there are certainly stories from China, even before Italy. I think a lot of the Italian, the events in Italy have been covered perhaps differently in the media, and so we've been more access to some of those stories. But it's been terrifying. I mean, we've heard stories from. There was, I think, a very affecting podcast that many people saw in JAMA with an intensivist in Italy who directs or leader in their regional network. So that's been a real problem. They've simply run out of ICU beds and run out of ventilators, and patients have died because of that. And that's, I don't think, anything in Europe or North America that we've seen. So that is a primary concern of ours. We have, and so because of that, you know, my focus and the focus of our leadership group really from the beginning has been on securing extra ICU capacity, and that began with, you know, the reduction of elective admissions, particularly over the last week, but also identifying sites for additional ICU capacity, and that's additional ICU units, considering the use of operating rooms, and then in tandem with that, really building ventilator capacity. I'd say we are in better shape than many. I can say UCSF Health right now, I get several of the leadership get a daily vent report. So we know what we have in use and what's available. And I'll put out there right now, we are tracking about 70 extra available vents right now that are available. We are building that vent supply. We also have many more OR ventilators, and these are all options that we need to consider, and there's certainly options that have been used in Italy. So that's where we are right now. I think that for me, beds, ventilators, and PPE are the primary driving concerns that I think about, and that our focus needs to be on right now.
Thank you. Maybe Sarah and Debbie, what are you seeing in infection prevention? I mean, in some ways you've prepared for this moment all of your careers and probably dreaded that it might actually happen, and here it is. So what has worked the way you thought it might, and what has been harder, unanticipated challenges as you know, this has all exploded on our doorstep over the last couple of weeks? Sarah, do you want to start?
Sure. I think some of the wonderful things that I've noticed, I'll start with those, have been the amount of teamwork and collegiality and willingness to jump into the fray that we've seen so many people at so many levels doing. And I think wouldn't say I necessarily anticipated that, but it's been really amazing. I think some of the challenges that Matt mentioned have been things that might have been anticipated, but are our biggest challenges really related to the supply chain, and that impacts every single step of the way. It impacts our ability to test patients, our ability to isolate patients, our access to protective gear. It is going to affect bed capacity, and that is what is keeping me up at night.
Yeah, Debbie, I think you're on mute, but go ahead.
Yeah, I agree 100% with everything that Sarah has said. First of all, the amazing teamwork and dedication of the providers who've been taking care of these patients, the physicians, nurses, the support staff, has been really amazing and inspiring to see. And also totally agree with the issues around supply chain. I think that these were issues that have been discussed in sort of a theoretical way for many years as we've been preparing for the possibility of a pandemic, but it has become a stark reality with our current situation. The other issue that I think has been very challenging is that this is a new infection, so we're learning as we go along. And that means that we have to sometimes change what we're doing in terms of our protocols and our personal protective equipment, and that can be very anxiety provoking for individuals. I think all of the things that we've been emphasizing in infection prevention for a million years now around the importance of basic practices like hand hygiene, adhering to careful donning and doffing of personal protective equipment, that just becomes even more starkly important in the face of this pandemic.
You have gotten our attention now. It took a while. Unfortunately, it took this. One of the issues that comes up all the time is surgical masks versus N95 masks. And I think one of the challenges is you read something like the New England Journal piece that came out a couple of days ago that showed that it can kind of linger in the air a little bit. And yet it sounds like the epidemiologic evidence is that you really can't catch it. Wearing a surgical mask is adequate unless the patient is actively undergoing some sort of procedure. How do you reconcile those two pieces of information, and how do you tell the workforce that a surgical mask is okay and convince them that that's right?
So I'll start, and then I'll let Sarah add to my comments. So as you mentioned, based on accumulating epidemiologic data, all public health agencies agree that the evidence supports that the primary mode of transmission is through respiratory droplets, and particularly among people who have close and prolonged contact, for example, household contacts. There's also the possibility that respiratory viruses in those droplets can contaminate surfaces, and some studies that support that. And that is why, in addition to what we use for droplet isolation, we've also included contact isolation with the use of gowns and gloves. So all of that does not mean that we don't believe that viruses can be aerosolized under some conditions. And so we do have a very clear caveat that during aerosol generating procedures that we do need to take airborne transmission into consideration. And so for patients who are receiving continuous aerosol generating procedures, we do require that those patients remain in an airborne infection isolation room, and that everyone caring for those patients is wearing an N95 respirator, plus eye protection or a PAPR, as well as gowns and gloves.
Okay, Sarah, how do you think this through, and what are you actually seeing on the front lines? I can imagine that all makes sense. You've read the information, you read the CDC, and it still feels scary to people to only, quote unquote, have a surgical mask.
Yeah, absolutely. I think it's really—
Sarah, get a little closer to the mic if you can.
Yep. I think it's really important to acknowledge that this is an anxiety-provoking time. This is unprecedented for all of us, and that the anxiety that people are just feeling is real and valid. And what I would say is that study in the New England Journal was
You're
done
cutting in and out, so I'll come back to you in a second. Let me up there you are. Go ahead and speak.
Sure. Can you hear me now?
Yep.
Okay. The study in the New England Journal was done in a lab setting, and how it translates into clinical practice is not entirely clear. What we've observed from the hundreds of thousands of cases now is pretty convincing that this is mainly a droplet disease, and I think the R0 supports that. Several case reports of varying exposures and the way it spreads supports that. So I think those pieces of data are very reassuring. And then the other thing I'll just say, I know people are asking a lot about the bunny suits that are being shown in stock photos that they're seeing from other countries. Having donned and doffed a lot of those in our Ebola preparations, you realize how easy it is to contaminate yourself doing that. It's unfamiliar PPE. And one of the real important things to remember is that we have less risk to ourselves if we use PPE that we're all familiar with and we're trained to use.
Right.
That's part of the reason we're using it.
So let me ask one more question of the two of you, sort of from an epi standpoint, then I'll get to Chaz and Brad. You see, we're being told this could be 3 months, 6 months, who knows? And then you see the curves from China and Korea, and they're fairly reassuring in terms of the sort of degradation curve and the improvements. What's the disconnect there? Is it that they were just so good about infection prevention once everybody figured it out, that they got better, or that this thing can come back, can roar back in a way if you sort of let your guard down after an initial period of vigilance? Why is it that we shouldn't expect, all right, this is gonna be a really bad month, and then 2 months from now, if we all do the right thing, we'll just be fine? Debbie, you want to take that?
Sure, I'll take that. So I think we don't know. We don't know whether our epi curve is going to be like what they're seeing in Italy, or whether our epi curve will be like what they're seeing in some other parts of the world. I do think that during the next probably 2 weeks, we'll have a much better idea of where we're going, whether the non-pharmaceutical interventions that we put into place, including the shelter in place and the canceling of schools and social distancing, whether that has been implemented early enough for us to prevent moving into a situation like they're seeing in Italy. I do think that it's important to do everything we can to push that epi curve over to the right, as you saw in the discussion by the previous speakers, to really flatten out that curve, to reduce the peak number of infections and to spread it out over time so that we are not seeing a huge surge of patients requiring hospitalization and critical care at the same time. And regarding keeping our guard up, I think that will be incredibly important because as was seen with SARS, I think once your guard is let down, once the practices go back to normal, it is very plausible that we could see another spike in the number of cases.
Great. And one last question, I guess, for you would be, when I see those, that flattening the curve thing, I think I failed calculus. I can't tell whether the area under the flattened curve is the same as the area under the steep curve. Is it the same number of cases, just distributed so Matt doesn't get overwhelmed in the ICU? Or is it actually a lower number of cases in aggregate?
I think that the hope is that it is both a flattening and a distribution of cases over time, as well as a decrease in the number of total cases.
Great. All right, let me turn to Chaz. Thank you for being here. So you're kind of our expert on virology and on testing. And so the world of testing has become incredibly interesting, and another area that we're all paying attention to and hadn't thought about until 2 weeks ago. So tell us what your take is on how things are going and what the experience has been here at UCSF.
Well, diagnostic testing, without doubt, is such a critical part of the COVID-19 response. It's really the cornerstone of many infection prevention efforts, and it's so essential for preventing transmission both in the hospital and in the community. Despite that, testing has really been a major challenge in the US. I mean, if we look at some of the numbers of test availability, if we look at South Korea, for instance, 5,000 tests per million people were available. The US comes in right around 100. So there's really been an unmet need for testing as part of the response to this pandemic. Things are changing, as we know. There have been some important milestones. Perhaps one of the most significant was on February 29th, when the FDA revised their guidance and allowed individual laboratories, such as the one at UCSF, to develop their own tests for this coronavirus. And that's really made a major impact in terms of allowing testing to happen at a much broader rate. Right now, testing at UCSF is at the rate of about 100 tests per day. These are efforts led by Steve Miller and Ed Doernberg in the microbiology lab. And there's really a lot of hopeful aspects, I think, in terms of diagnostic testing, especially during a sobering time. I think one of the most exciting is the new extension of the UCSF Clinical Microbiology Lab to the space below the Chan Zuckerberg Biohub, which is on the Mission Bay campus. Over 100 people, 100 scientists, physicians, graduate students, volunteers from UCSF have come together, led by Joe DeRisi, Steve Miller at Doernberg, and have essentially built a CLIA diagnostic lab in less than a week. And that's anticipated to bring UCSF testing capacity up to 300 plus tests per day within a few days, and up to 1,000 tests per day within a week. And so that type of teamwork, that's been discussed on many fronts. The hospital infection prevention front is really one of the best aspects, I think, in terms of the response. A few other comments I'd just like to make. Jen Babik noted some of the challenges in terms of diagnosis of COVID-19, given the non-specific clinical features that are shared with many other types of respiratory infections. There's really a need for tests to be able to broadly and in an unbiased way distinguish between different types of respiratory viruses and identify co-infections. And then the topic of biomarkers came up. That's certainly one of the key diagnostic testing challenges. Can we predict outcomes of patients with COVID-19? Can we predict the risk of progressing to ARDS, the risk of progressing to death, especially as we anticipate a situation where resources will be limited? Such prognostic tests will really be essential, I think.
As you think about testing, Chaz, a lot of emphasis on how many, and I hear less about how fast. And it strikes me, we'll take it to Brad in a second, but there are a bunch of people in the hospital today waiting for their test to come back. I know the turnaround is 12-ish hours or sort of thereabouts. Are we on the cusp of much faster, and how would that make a difference if we had it?
Yeah, I think we are. So I think the turnaround time at the clinical lab now is on the 6 to 12-hour time frame. There are some exciting possibilities on the horizon for more rapid diagnostic tests. One, for instance, developed by a group at Mammoth Biosciences, uses a CRISPR-Cas12 technology. Charles Chu has done a lot of work on this. That could reduce the turnaround time to a matter of hours. And then I think rapid serologic tests, point-of-care tests, similar to our rapid strep tests, have been developed in China. Those are not yet available in the United States, but potentially could be a useful tool. The more rapidly that we can triage patients in terms of understanding their COVID status, the better we can use limited supplies of PPE, the better we can use our healthcare workforce team, and the better we can understand transmission and exposures in the hospital.
And talk for a minute, and by the way, I've just gotten word that we can go past 1:30, so if you guys can all stay, we'll go to maybe 10 minutes over. Is that okay? I'm looking around, shaking heads, sort of, yes? Yeah, good. Okay. In terms of the testing, talk a little bit about test characteristics, sensitivity, specificity, and is a negative test totally reassuring? Can you be positive when you're asymptomatic, as we heard some of the basketball players seem to have been? Tell us a little bit about how that all works.
Yeah, these are all very good questions, very important questions. So asymptomatic people certainly can be positive. That's now a well-described feature of COVID-19. In fact, the ability for asymptomatic individuals to transmit is thought to be one of the main reasons why this has become such a problem. So, for instance, in contrast to the original SARS coronavirus, where patients were infectious and could transmit after they developed symptoms, this appears to be happening before patients actually develop symptoms, making testing of the population more relevant and important, and making control of this more challenging. In terms of the test characteristics, we can think about different specimen types and sampling sites in terms of understanding sensitivity and specificity. By and large, coronavirus tests for this coronavirus are PCR-based tests, which are highly specific and highly sensitive, but the sensitivity varies significantly depending on sampling type. I think, as Diane mentioned, viral load is very high in the nasopharynx, but looking at tests comparing a variety of different specimen types, we're looking at a sensitivity on the order of about 75% for a single NP swab. If we look at oral pharyngeal swabs, sensitivity is lower than that. Depending on the study you look at, between 33% and 65%. We know that there's some added value if you combine two types of swabs. If you sample at 2 sites, you get about a 10% sensitivity bump. So that would bring things up to 85%. And since this is really a lower respiratory tract infection, sampling in the lower respiratory tract is optimal. There was one recent JAMA paper that suggested a sensitivity of over 90% for BAL sampling. You know, the exact test characteristics, I think, are still to be worked out. The question of what is the gold standard here is often an issue. Is it a clinical diagnosis of COVID-19? Should a composite of all different tests be used to determine the gold standard? These are important issues, but I think we're talking on the order of 75% sensitivity for a single NP swab, which is the standard sampling approach. And so a negative test does not rule out infection in someone with high suspicion.
Does that worry you? I guess if I were thinking that through and saying, I'm going to get a test, it's negative, and the patient gets the message, you're good to go, you don't have the disease, and then whatever flows from that, maybe they're less careful from an infection prevention standpoint, or don't wear a mask or whatever, and there's a 25% false negative rate. That sounds a little concerning.
You know, I think it really comes down to the need for a clinical perspective and clinical assessment of the patient. And if it's someone being admitted to the ICU with acute respiratory failure of unknown cause, their respiratory virus panel PCR is negative, their NP swab COVID-19 test is negative, that really speaks to the need for an additional test to be done. So I think these types of pre-test probability assessments are really important.
Okay, thanks. Bradley Monash, how are you? Lovely background. You are helping to run the hospital medicine group's response to all of this, and most of the patients will come through the emergency department and come up to hospital medicine. So I understand the entire group has been mobilized and has created a distinct floor to cohort these patients. Tell us how you're thinking about it and how that's gone so far.
Yeah, Bob, this has been a transformational, unbelievable experience on so many levels. As we've seen our country, our world go through this together. The unit that you're referring to has been named the Respiratory Isolation Unit. The RIU, 15 long, has been transformed into a pandemic ward, which is modeled after sort of similar wards that exist globally, including in Singapore, where we've been in contact with colleagues. And so a tremendous team effort to do this. I won't have time to name everybody who's been involved, but it took a village to essentially shut down the unit, increase our capacity to have airborne isolation, negative pressure rooms, make sure that every detail, every stone was left unturned, train an entire unit of staff and nurses to care for patients with acute respiratory illness and patients who are ruling out for coronavirus. And the intention is for this to really serve as a closed staffing model type unit. And so providers show up, they put on scrubs, a shower will be available, there will be meals served in the unit. Massage chair, I understand, is going to be delivered there as well. There will be twice daily rounds with our chaplain and spiritual services. And really it's this opportunity to build an incredible interprofessional team with a shared mission of caring for this population, not only for their physical disease, but also you can imagine with everything that is coming through the news media, there's a tremendous amount of emotional, psychological distress on this particular population and their families. And so even those patients who have extremely mild respiratory disease, the amount of time and care required to really care for them is tremendous.
Let me ask you, probably Matt, as well, about the emotional distress. One element of that is that the city of San Francisco, and I guess maybe even broader guidelines now, are to basically say no one can have visitors except for end-of-life care situations. And so these patients who are scared that something terrible is about to befall them are sitting there essentially by themselves, family members kept away from them. That's got to be incredibly hard on patients and families and the people taking care of them. How are you and how are our people dealing with that?
So this is really challenging. As we can imagine, we pride ourselves on sort of patient-centered care, and this is much more population-centered care that we are practicing. And these measures that are to benefit our greater community definitely come at the expense of individual interactions. And so a few people have mentioned how inspiring it has been to see folks spring into action and take initiative. And so I saw a bunch of emails in the past week from hospitalists who really want to make an impact here. And for example, repurposed our video interpreter polls to have more FaceTime interaction. I know there is an effort to try to consolidate iPads throughout the UCSF Health to get them into patient rooms to allow more sort of FaceTime type interactions. And so there's a tremendous amount of effort to preserve the critical human interactions that are important for our regular day-to-day lives, but also for health and recovery.
And Matt, how are you folks thinking about this? You're seeing a few patients, and are family members being allowed to come up or not? And how do you talk to a family member who's not being allowed to come up?
No, we've had to limit. I mean, we've had to participate in the visitor restrictions like every other unit has. And for us in the ICU, the impact really at this point, because the number of COVID-19 positive patients that we've had in the ICU has been relatively small, the impact is really on the other 50 plus ICU patients who don't have visitors. And so we've been able to make some exceptions, but it's challenging. This is just, it's a brutal time for many patients who up until a few days ago had the support of their family and their friends, and now don't have that anymore. And so we have made exceptions at the end of life, but that's also that's a difficult clinical judgment for all of us, right? There are many patients who are critically ill in the ICU, and you know, there's one circumstance where there's made a decision's been made to transition to comfort care, and that's, I think, clear, and that's when we've certainly made exceptions there for family visitation. But then there are other circumstances where we have patients who are chronically critically ill and vulnerable in the ICU, and they've not been able to have access to family members. So it's been obviously incredibly hard on patients and their families, but also on all the staff, the nurses, respiratory therapists, the team members who are taking care of the patients. So I don't think there's an easy answer to this. It's just, it's an unprecedented time for all of us.
Yeah, thank you for bringing us back to, as I recall, the world 3 weeks ago, our hospital was packed with sick people, and they've not gone away. So what is your sense of, you know, I mean, we're opening up beds for COVID patients, but those other patients who used to be in our hospital, many of them are still here. So what's the impact on them? And also, we're now turning away patients who otherwise would be here or would be getting elective surgery. How are we managing this sort of triage function?
I think we're managing it as best we can. I mean, there's clearly some procedures and some admissions that are elective and can be pushed off for several weeks to months, and we've done that. There are others you're right. I mean, there are patients with, you know, certainly there are surgical patients who need to come to the ICU because they have emergent or urgent needs, and we need to take them to the operating room, and we will continue to do so. Obviously, it's all now in an environment that's much more challenging for everybody. And so we're, as you know, and everybody on the panel knows, and I'm sure the 2,000 plus participants still listening, I mean, it's a daily discussion. I mean, it's so dynamic, and every day we come up with a plan, and we come up with algorithms, and we come up with pathways, and then something shifts, and then you have to adjust your approach with that. So there's still active care for these patients with urgent needs, but it's just simply being done in an environment that's different than any of us have ever practiced in.
So we only have a couple of minutes left, and I appreciate everybody's indulgence for going over. Let me just give everybody sort of 30 seconds to sum up. And I understand the instinct to just say thank you and shout outs to the extraordinary work of your colleagues is real, but probably less helpful than something that you have learned or has surprised you along the way, or that you're scared about as you think about the next few weeks that you haven't already heard or you haven't already had an opportunity to say. Anybody want to start? Sarah, you want to start?
Sure. I think my biggest fear is that we stop practicing evidence-based medicine. There's a lot of emotion here, and I've seen a lot of people throwing anecdotes around and reacting to stories which are understandably eye-opening and sobering. But I want to urge people to continue to read the literature with a critical eye and do what we think is really best for the patient. We should
unpack that for us. What is a typical thing where you see people not practicing quote evidence-based medicine?
Well, I mean, just some of the treatments that are being thrown around that I've seen other centers pulling the trigger on treatments that really have the potential to do harm to our patients. Things like tocilizumab, where there's really very little data to support it at this point. I am definitely enthusiastic about studying these in rigorous trial settings, but just starting to give therapies that might cause harm concerns me.
Okay, great. Chaz, anything that has surprised you or that you're thinking about going forward? And go off mute.
On the topic of things that are concerning me at the moment, of course, there are a number, but on the diagnostic testing front, one is a critical need for nasopharyngeal swab kits. We've been told that the federal government is releasing their strategic stockpile of nasal swab kits. I didn't know they had one.
Isn't that amazing? There is one. Yeah.
But those have yet to reach us here, and that may very well be a rate limiting factor moving forward. But I think there's a lot of good things to come on the diagnostic testing front in terms of expanded capacity and availability to do more broad screening, including drive-through screening of healthcare workers and higher risk populations, and then the general population.
Great, thank you. If we're sitting here in a $5 billion a year operation, one of the top medical centers in the universe, and the fact that we're going to get thrown for a loop because of fancy Q-tips is pretty unbelievable, but I think that's actually, there's some truth to that. Brad.
So this has been just an incredible experience in so many ways. And lately I've been reflecting a lot on this concept of the cortical and limbic aspects of leadership. And this has been the most challenging personal experience I've had as a leader, to try to lead a division of medical service in a time of crisis and a time of panic. I've learned a tremendous amount from our palliative care colleagues in how to communicate, because we learn a lot about bedside communication when there's a tremendous amount of anxiety and despair in the room. And this is a time when we are communicating with a health system where there's a tremendous amount of anxiety and despair. And so I've been reading Harvard Business Review and thinking about how to lead in a time of crisis. And it comes down to just a few key principles of slowing down, of maintaining mindfulness, which I recognize as a buzzword, but if people really study mindfulness, there's some real power to that. It's about maintaining human connection and connectivity. It's about the critical nature of communication and rethinking how we communicate in times of crisis. And so I know many of us are turning to frequent town halls, frequent communication, allowing opportunities for folks to engage and interact, which is becoming ever more important in an era where we are having social distancing and less human interaction. And then the final lesson for me is just the critical importance of empathy and leading with empathy, and the power of just thinking right to the person in front of you, how can I make this person's day better? And if we can all have that mind frame, we can really, I think, revolutionize and change our current mental state. So this has been an incredible learning experience for me. I'm learning and growing every day. I realize I'm making a lot of mistakes, but just trying to do better.
Great, thank you. That's really important and profound if you think about the importance of community and connection, and the irony of we can't do it in the way we normally would do it because of the nature of this the virus. Matt, we'll close with you. What are your thoughts?
I really want to agree with Sarah's statement. I think, especially in this time of real concern and uncertainty, I think it's critically important that we stay focused on what we know to be evidence-based medicine, and that we not get distracted from that. I think that certainly matters in critical care and in other parts of treatment here. And then for me, it's just I'm grateful to live in an area where our government officials made hard decisions and earlier than other areas, and I like everybody else, I really do hope that changes the curve over the next few weeks. But I also am am very mindful of the fact that over the next 2 weeks, we are still prepared for the fact that the surge is there and likely to come. What that looks like exactly, whether that's just very hard or whether that's potentially overwhelming, we don't know yet. But we need to continue to do everything we can each day over the next few weeks to prepare for that. And we hope in 2-3 weeks' time, the decisions made a few days ago really start to show an impact. But that's what we really need to focus on going forward.
Well, I want to thank all of you and the prior speakers. I've been at UCSF for about 100 years, and I've never been more proud of the organization. And to me, this is an organizational stress test, and it's extraordinary. The response, the teamwork, the collaboration, it's quite heartening. We will do, as long as this is going on, we'll do grand rounds like this every week, every Thursday at noon. Next week, we'll do something on the more academic missions, either on the research enterprise or on our educational enterprise, or both. We're still sorting it out, but assume we'll be doing something. And again, these are the Department of Medicine grand rounds, but the intent here is to be for a broad audience, including all of our colleagues at UCSF and maybe even beyond. So thank you all for joining us today. Thank you to the speakers for superb presentations, and everybody be safe and continue to do the extraordinary work you're doing. Thanks very much.
Thanks, Bob.
Thanks, Bob.